All right, this episode was so much to cover that we've actually broken it up into 2 days. And so this is the start of day two. Yesterday we talked a lot about how Shawn got into telemedicine and leading as the... What was your position at MUSC?
So I started as the director of telehealth, and then when I left, I was the administrator of telehealth.
Administrator of telehealth. Great. So you were
Yeah.
very much on the administrative operations, making sure things up and running. So great insights there. And we talked about the whole from 2013 all the way up to, we didn't really touch on COVID. That's what we'll talk about today. So COVID was just a completely out of the world experience for anybody that's in the telemedicine space. And talk about what that experience was like from your perspective as an administrator of telehealth for a large health system. What was the first indication that something was happening? What were the conversations like with the leadership and the C-suite, and what was your experience like leading this? And I'm pretty sure there were a lot of sleepless nights. So tell us about that.
Yeah, no, it was an extremely busy time period for us when. We had a provider, Dr. Ed O'Brien, who was leading our virtual urgent care, who did a lot in global health. So he was early on when things were, about to hit the U.S., I think, or maybe just hit U.S. soil. He was like, this is the real deal. This is going to blow up. We need to prepare, And so there was a sense of urgency in our center before there was, overall within the state of South Carolina. But even then, I think still didn't fully appreciate what we were about to endure. Because I remember I took the initial lead of like, hey, let me take the point on this. This is pretty important. I was about to go to a conference. I was like, I think I'm gonna cancel going down. And I think it was like hymns or something. I was like, I'm not going to go. Yeah, I'm not going to go. I was like, I better just stay here and let's figure this out. And I started to put some things together, and it was probably within the first 5 days of planning. I was like, I think we need all of our leaders, we got to start separating and delegating things out, because we realized that there was going to be different entry points, and it was going to be way more like it wasn't going to be manageable for someone to say, hey, I'll just handle COVID. It was going to be like pieces out. We started, after like a week or so, we started realizing this is going to completely change the way, we're going to be delivering care. People are going to be accessing and stuff. So we started separating, and we had a big mapped out strategy, a pandemic response strategy, leveraging our existing tools that we already had. We had thoughts like, hey, we'll use this for this, we'll use that for that. So we had kind of the virtual urgent screening, which I got heavily involved in. We had, when patients come to the hospital, how are we going to keep our staff safe and still be able to treat patients? So we had a hospital strategy around it. We had all the patients that go to ambulatory care clinics, we actually had a clinic, that MUSC had that they closed down because of an exposure early. So it was the mindset of like, we're going to be flipping, pretty much all of ambulatory care virtual. So there had to be an ambulatory care strategy. So there's different pieces. There was a remote patient monitoring strategy that developed of, all right, when patients are positive and either they're not sick enough to be hospitalized or maybe they get discharged, how do we monitor them, kind of that hospital at home model, to make sure that we have some involvement. So there was different things broken off, and things just lit like a fire in the early stages.
And what things went really well, better than you expected?
I don't know. It was better than I expected. I think. Well, probably the biggest thing would be that. For the very first time, we had every single person within our organization, and this is true for any health system during that time period, where everybody had the exact same priority. So it wasn't anything in regards to, hey, I gotta see if I can get a meeting with legal this month, to ask them about this, new law. It was I had the full. The whole full legal team saying, Shawn, we will review every single thing that comes up in regards to evolving state regulations, federal regulations. As this emergency evolves, we will give you, updates, and we can make decisions from there. And I'm like, Wow, that's fantastic. Because it was you. It was typically myself
Yeah.
reading all the stuff that might come every couple months
Yeah.
or whatever, and then having my interpretation, and then getting a meeting and saying, "Hey, am I interpreting this correctly? What does this mean for our service?" But it was, everyone else was getting out in front, which was phenomenal to have everybody kind of rowing in the same direction, and to realize, what an organization can accomplish in such a short period of time when you have that type of strategic alignment. And I would also say early, I still have it in my phone written down. It was within the first week, but I remember I put it in my phone, which people often would, say during the early times of, never, whatever is about, never let a crisis go to waste type of situation. You know what I mean? And so I was thinking about that early because I was like, we were trying to get a lot of things going with remote patient monitoring in regards to compliance, EHR build, and we had conversations. It is even before we realized how big COVID was going to be. It was like, man, we can get all this stuff built for us. So we've been trying to get built for like the last 2 years, and then we'll just use it for like COPD and CHF and all these other, chronic conditions. And so that really kind of moved things along at a rapid pace. So we were already thinking about that, like how can we benefit from an infrastructure that will give us long-term, sustainable, benefits downstream, which it definitely did.
Definitely. I mean, that's, I think so many people have seen that. Just everybody got a line behind it, and barriers that existed before no longer existed anymore. Now, talk about some of the, what were some of the mistakes or failures that you experienced during COVID that you're looking back, you're like, I guess we could have done that different.
Yeah, I don't know if it would be mistakes. I think it was just, we would discover quick inefficiencies and then try to address them right away. One of the first, MUSC was one of the first, if not the first on the East Coast to virtualize the screening directly into the drive-through, right? And so we had a lot of success with, virtual urgent care. Well, we were doing about 3,000 virtual urgent care visits a month in January and February, 4,000. And quickly, we modified the platform to be able to screen for this asynchronously. So, at that time, you'll hear about some of the big telehealth players were having trouble with the demand that was coming at them because they were using the traditional either video or telephone interaction, which could take 10 to 12 minutes to make an assessment. Are you high risk where you need additional testing? Where we were able to do that in like 60, I think it was like 89 seconds was what was determined. 89 seconds per encounter, we will say, yes, you're high risk. You were outside of the country. You were high risk. You had a direct exposure, to someone who was COVID-19 positive. And then we continue to develop a more streamlined system to get them into a drive-through clinic. At first it was, manual processes between the two, like we had the system and then like people would go through like who got the order, and then it was getting that into the electronic health record. Then we were able to get that order directly into electronic health record to speed that up. Once they got tested, one of the clinical departments early on was calling every single person who got tested and telling them, hey, you were positive, or even calling negatives and saying, no, you were negative, you're good, all this other stuff. And, think about the demand that was coming through. You're talking about hundreds a day eventually coming through, getting tested, hundreds and hundreds. And next thing you got a big backlog, because they're taking forever to have this, could be a 5-7 minute conversation with each individual. So notifying 100 patients that they're negative would take you all day. Now they have now they're like 4 days behind. We were able to use a tool that we were working on around this prenatal maternal health situation where we were going to push information out to text messages to a mother of prenatal information, and then postpartum be able to check on the mental health of the mother, check on how the baby was doing with progression, check on do they have resources, adequate food, all those different things around the mother-baby time period. And we hadn't launched that yet. But we ended up flipping that application that we were working on developing and use that as a notification tool of text messages in regards to, they were still, reaching out directly for positives. Right. But all of a sudden, as opposed to taking 8 hours to notify 100 patients that they were negative, we were able to do that in a couple minutes. And so just like that type of, so it was things like that. It was like we would learn things like, oh no, don't do that. Like we got it. There's a more efficient way. So we continue to identify more ways to make things more efficient throughout the different time.
And at the beginning of COVID, everybody went to telemedicine, and very, very few things were done in person, except actual COVID cases or emergency type care. And then it started to trickle back, slowly coming back in. What did you see as people were starting to go back? It wasn't just a light switch. You just switch on, everybody comes back in person. You started to see that creep back up. What were you seeing in the change of attitude and perception about telemedicine as a result of COVID? And what were the preferences that you were seeing from patients and providers after having the opportunity to do telemedicine and seeing how it could be done?
Yeah, I mean, it was definitely a mix, and it depended on a lot of different things of the digital literacy of the patient population. There's a lot of discussion on that right now, and needs to improve that throughout our country. Whether it's an aging population, patients in rural locations. Same thing with our providers. Providers that weren't able to use the technology. I think that became an interesting time period for a lot of health systems that may have had an investment on a certain technology and said, "Hey, this is our solution." And maybe they were using it for different reasons for telehealth. And then when they had to use it for getting into the homes, it wasn't super user friendly. Your platform is a great example of a super user friendly platform that people were able to, hey, this works a lot easier, and people were adopting it easier. And so that's when I think the mentality shifted of like, let's not make this too complex. It's got to be easy for the patient to use. It's got to be easy for our provider to use, because a lot of health systems, unfortunately, set people up, not intentionally, but they set them up to fail of saying, hey, here's the technology, because they had to do everything so quickly. Here's the technology. They would push that out to their providers, tell them how to do it, and then sit back and like, I hope this works, without the, so they took away the kind of pre-visit assistance that you would typically have, at the front office when someone would come into an ambulatory visit. They took out the nurse or the CMA, who's not only there to get vitals, but often there to help the provider navigate other things. Like, where's this chart? Where's this information? There are just so much things that go on in the clinic that I think got lost during that time period, which made providers frustrated, rightfully so. And so, it was interesting, like, especially after, 6 months in the pandemic, and people were like, oh, we're doing telehealth now. Like we've got this. And I'm like, and because we knew, a lot of people knew that, like, well, they were set up in a rush without a clear strategy, clear training, clear way of how to do this. And within 6 months, all of a sudden, maybe even less than that, you started hearing providers. Now we've got providers using multiple different systems. We've got, everything started to break down for a lot of health systems, and they realized, okay, we did flip things virtual. People were very adaptive at first. I think that's the thing. There was a lot of grace that was given by both the patient population and the providers at first that you typically would not get in a telehealth implementation. Right. The patients, typically, if something went wrong with the technology, they'd be like, oh, this is horrible. But, if something went wrong, they're like, hey, I'm just glad I have a safe way to see you, And the same way with the providers, if something went wrong, they might have been really frustrated, but they're like, hey, this is what I got right now to reach my patient population. I'm grateful that I have this. So there's a lot of grace, but, that wears off after a while, And so you start to see that where people start to revisit, like, well, you know what, we probably need to relook at what we did because it was done in such a rush, and let's think more strategically. Let's think of the development tasks that need to be accounted for with, compliance with billing and everything else. Of course, a lot of the regulations got lifted, during that time period, which was nice, that people can scale quickly. But the sooner people started to think about, all right, what's the long-term sustainability? How do we create this, build this to last? The better, and people start to move on from there.
You mentioned that 6 month mark where I think very much so the first 6 months is like, whatever, we just got to be using things. And then about the 6 month mark, people were like, hey, this COVID thing is not going away. let's like figure
Yeah.
out how to optimize this and do it right. And they started,
Yeah.
thinking about, does it make sense to be going through all these steps, or maybe we should like get a contract with this, whatever, and do it. Did you see a difference in like what were the biggest requests that people had as they were kind of adapting to this new normal? What were their biggest pain points that they were struggling with?
A lot was around IT support, or education, from the provider side of things, that making sure that they had someone who's going to, typically when we would implement telehealth services in the past, there was a lot of hand holding. And when you had to do this big at scale so fast, we lost that hand holding, so I think that was the time point of like, all right, we need to revisit this. And we start, at the center, we started to strategically think about like our personnel resources and how we could divvy things back out to have, key people, operational people that can work with different service lines. So they had a key contact, to be able to say, all right, here's the resources, but we're also going to give you a clear point of contact, because a lot of jobs got reshuffled, right? Like, I mean, we had school-based telehealth nurses that the school shut down. So, but we had a skill set, so we shuffled them into virtual urgent care and reviewing things. We had them review, some that didn't come through the platform like initially, but because when we set that up, I mentioned like we were doing like 3,000 a month, January, February. We ended up doing 32,000 a month in March, and we set that up. It was like, all right, now we got to say, we got those through. I remember our chief diversity officer, Anton Gunn, shout out to Anton. He was like, Shawn, this is great, but can Spanish speaking patients get through this? And I'm like, no. So we set that up in like less than a week, where they had a route, and we worked with Dr. Vanessa Diaz and had a route for Spanish speaking patients to come through and get evaluated. And I remember just like, we did it in less than a week. I was super, super happy. And I was like, man, this is great. Anton, I got you, Spanish speaking route. He goes, fantastic. I need something for someone who doesn't have internet, at all. And I'm like, give me a minute, and so we set up a phone line option for someone who would not have internet access or couldn't get to a device to be able to use virtual urgent to get through a screening. We used our school-based telehealth nurses to be the ones that would screen for that. So there's a lot of like moving around, personnel during that time as well. It was just such a fluid and dynamic, time, but exciting time. It was just like, a lot of people learned a lot. Obviously, the industry got pushed forward. People would say whatever, 5-10 years in such a short period of time, which is definitely the truth. But now it's like hopefully like people learn from those lessons and start to push themselves even forward and not just go back to kind of an old school way of thinking.
You mentioned that the industry got moved forward 5 to 10 years in a matter of months, and kind of your job at MUSC was to expand and get to this point where telemedicine was ubiquitous, and ta-da, it happened. You did it, and is that feeling that, hey, you crossed that line, you finished that? Is that kind of you're like, you know what? I've mission accomplished here at MUSC. I'm looking for my next challenge. Is that what prompted you to move on to your next thing?
Not completely, but maybe. I don't know. Maybe subconsciously it did. I think, I got approached about a position, and it was in correctional healthcare. And my first thought was, there's stigmatism around correctional healthcare, and I'm happy where I'm at. Yeah. But I had a former mentor always said, never pass up a conversation. And that first conversation, was with my now boss, and he's an ER physician, great, phenomenal guy, great vision. And his vision was, hey, listen, correctional healthcare has been done a certain way of a kind of a centralized business model, decentralized clinical care, and I want to change that. I want to redesign the way care is delivered using telehealth, other digital health applications to be able to, improve the efficiency of the way care is delivered, improve access, improve the cost effectiveness of the way we deliver care, to standardize the way care is delivered for this extremely vulnerable population, overlooked population. And I'm like, you're speaking my love language right now. So I'm now, you've now got my attention, and that changed a lot of things. And, and having conversations with folks at MUSC, it was because the whole mission thing came up, like, is a mission accomplished? I was like, you know what? I know I don't know if the mission will ever be accomplished. You know what I mean? I could do this for another 20 years. I don't think the mission's accomplished, but I think I grabbed the baton when I did back in 2013, and I ran pretty far, and I think it was at a point where I was ready to pass it on to somebody else to come with new ideas and new thoughts and take it even further than I could have taken it. And then yeah, give myself another mission, another journey, where I can impact another population. Because I mentioned about the stigmatism. I've had friends, growing up that were in the system. Visiting friends in jail when I grew up outside Pittsburgh. Visiting a friend that spent years in the Pennsylvania DOC, and so I had that personal connection too around that. And I'm like, you know what, if I just sit on the sideline and say, yeah, that's, people talk about the care and corrections, and I actually have been given an opportunity, I've been presented an opportunity to actually make a positive impact on that. And I knew my skill set and what I potentially could contribute to that. I mean, what can I say about myself if I didn't jump at that opportunity and say, yeah, I'm going to jump in the ring and I'm going to see what I can do and hopefully contribute to make some positive changes in the care we deliver.
Well, you certainly have the background, the skill set to make a difference. So you've got that vision of improving things. What are some of the specific strategies that you guys are looking to do and roll out and what are the outcomes you're looking to achieve?
Yeah, I mean, some of the big things in correctional healthcare, like I said, correctional healthcare gets a lot of a bad rap. It's interesting because of the Eighth Amendment, our patients, inmates, people with justice served population, actually have a guaranteed right to healthcare, which is very unique from anybody else. You and myself do not have a guaranteed right? There's always the debate: is it a right, is it a privilege? Well, as of right now, it is a privilege. No one has the right outside the walls of a correctional facility. You might get it from your employer or anything else, but a lot of people that don't have it, right? It's not a right. But justice served populations are protected, where they do have a right to health care. So that brings a very litigious environment. It's a very challenging environment because of course, people talk about understaffing everywhere else in healthcare. Typically, a lot of facilities are challenged as well with staffing problems, and you've got patients who are in a housing unit, and they have to be transported by custody correctional officers to a clinic area to receive care. And if there's a shortage of correctional officers and they can't transport them, then we cannot provide that care. But we get caught up in that as well. So when I first heard about that, the internal mobility challenges of that. So my thought there, and this is something we're not doing robustly yet or anything, but trying to put strategies around. I'm like, listen, if patients need to come to the clinic area to receive care, and we know that mobility is a challenge, getting them from their housing unit, then we need to rethink our strategy, and we need to figure out how to get that care into the housing unit, as best as we can. So we're looking at those types of things of how could we bring care to the patient. Again, typically you would do in the community. What are your challenges? What are your barriers? What can you do strategically to mitigate those challenges and barriers? So, mobility internally, also externally, getting patients out into the community to be able to see, a cardiologist or an oncologist. There is healthcare costs related to the transportation. There's taking those correctional officers outside the facility to transport, where again, they may be already short-staffed. So that brings safety risk of removing correctional officers. It's safety risk of bringing, the patient outside the walls. So we're setting up telecardiology clinics, in facilities right now. We're running those clinics and a lot of other specialty care inside the facility to bring that expertise inside the walls. And then when they need a certain test or intervention, then we'll get them sent out. But we're able to screen for a lot of things, get them sent out for when they need certain tests. When they come back, able to manage things, keep their conditions under control. I mean, patients are always going to have exacerbations, and they're going to have to go out, whether it's to a hospital or whatever. But if we can do more to bring in the expertise to be able to mitigate those exacerbations and get them, get their diabetes under control, their CHF under control, so they're not having exacerbations or asthma, those types of things. It improves the overall care that we can deliver.
It's interesting, and I think you've described this to me before, but the corrections population is a controlled population, and you control what goes in and out, and then you also control the cost of it as well. Where in the public healthcare, you've got payers all over the place. You got patients making their own decisions. You have less control. Where in this population, it is a lot more controlled, and you have a lot more control over what happens, what does and doesn't happen, which can affect outcomes. So you have more direct impact on outcomes. Talk a little bit about that.
Yeah, it's a great question because, and that was another reason. One of the variables that contributed to me coming over was I've always considered myself a population health geek. So I've when learning about it back in MHA school, over a decade ago, and I used to always tell my respiratory therapist, population health, value-based payments, everything's going to be like this in the next 2 or 3 years. This is like 2010 or something like that. And here we are 12 years later, and it's like 38-40% of payments are in that type of model. And it's taken, we've made a lot of leaps just to get there recently. But I've never been in more of a population health setting. So I'm like, I'm in love with this like model, but I've never really, done it myself. And so I just thought like, this is a great opportunity to be able to be in that type of model where we have we have 3 big buckets, I would say. There's kind of like the pass-through contracts where, the healthcare costs come in and there's payment based on those costs. There's really like, no or limited financial risk to us. There's then full risk where we're saying, hey, we're going to take care of this population. And it's everything. It's like, it's the cost of the doctors, cost of the nurses, often mental health, dentistry, the pharmaceuticals, the offsite trips, the ER visits, the hospital, all those different things could be included in that. And we're full risk for that, And then there's things in the middle that have different caps and stuff. And every contract's completely different, some we have mental health, some we don't. Some, might be another company. Some states have, Medicaid expansion. So the cost of inpatient costs fall on the state where, if they don't, it would fall on, us under that situation. So there's different things like that. But yes, when you're in a more full risk type of situation, then all of a sudden it is our ability to say, okay, what tools can we use to provide the most effective, efficient healthcare to keep our population healthy? Because if they're going out, then that's, it's a negative to us if they're going to be, hospitalized and things like that. If they need it, then we have to, do that. We want to do that, but we also want to make sure that we can keep them healthy. We want to prevent the exacerbations from happening. We want to identify things up front so they don't get worse down the line, I say, corrections get a bad rap, there's things that are not ideal. There's just like, they're not ideal in normal community healthcare that need to be improved. And, but those things don't change overnight. So that's a big mission of our organization in regards to improving the quality of care delivered. And, we actually recently got third-party validation from NCQA for a lot of our population health programs in 5 different condition states like HIV, Hep C, hypertension, other things like that. Because again, we were the first in corrections to do that because we wanted that to be a foundation of moving forward. Like, listen, we're going to have a third party that accredits groups like the Cleveland Clinic, the Mayo Clinic. We want that same type of overview and review on our clinical programs, which we got that, awarded, which was a great validation of a lot of the team's efforts. And we're going to start spreading those types of programs throughout the country. And again, it doesn't happen overnight, but it's humbling to be just a part of that.
Now, at WellPath, do they get paid a set amount per covered life, and then it's up to them it's up to the organization to figure out how you're going to spend that money and
every contract it's so unique. I mean, every contract is so unique but there might be they talk about ADP as like an average daily population of how many patients are in a facility on average. So there may be contracts set up where there's a financial payment for a set number, and you're obligated to be able to take care of that patient population, and so because you have to match resources, right? If there's 20,000 patients versus 1,000 patients, obviously the resources and effort needed is significantly different. So you have to match those things. But yeah, it's so unique in regards to, I couldn't even begin to explain it because I don't have a full understanding myself, beyond that every contract's unique, right? In some contracts we have pharmaceutical costs, and some we don't. In some, a lot of our facilities, they're WellPath nurses. In some states, they're not, because it's a unionized state, and it's state employees as nurses, and so it's our providers, our doctors, nurse practitioners, physician assistants working alongside a state employee. So there's just a lot of uniqueness like that, and every state is different, just like in telehealth laws.
Yeah, no, yeah, absolutely. But telemedicine and what you're doing is looking at, okay, what can we do as an organization to reduce costs wherever and provide better quality care as well. It's not just about money, It's also about providing quality care through telehealth.
Yeah, I mean, to me, I'm always been a quality process improvement person at the core. And so one example of things we've done is, I talked about transports out, where there would be, say on average, there's a facility that has 100 ER transportations. Typically, out of those 100 transportations, 60 of those patients get evaluated and come right back to the facility. And so that's, taxpayer money at the site, that's correctional officers leaving, that safety risk of pulling that, patient outside the facility. There's just a lot of things that they're involved in that. Typically it's 2 correctional officers that go in those transports. So we developed a service called WellPath Now. It's an emergency medicine telehealth service where we're able to bring in emergency medicine expertise directly to the facility where our patients are located. So that way, when we have exclusion criteria, like if they have stroke-like symptoms or an active labor, those types of things, you don't use the service. You get them out to the ER immediately. But if there's any we're not sure, we're thinking about sending them, bring in an emergency medicine provider, right? It's like bringing a virtual ED directly to their door to have that second opinion assistance. And so a lot of times it's a nurse initiates that call, but we've had physicians and nurse practitioners initiate that call saying, hey, I was thinking about sending this, but I'm thinking it might be something different. And then people call in, an ER physician with 30 years experience or whatever, and to be able to develop a treatment plan that's safe for the patient. We've had a lot of success. We've done over 15,000 encounters over the last year and a half using that service. We're now in about 300 facilities across the country. And our providers, they're able to respond to these emergencies on an average in less than 5 minutes. So typically it would take 30, 60 minutes or more before that patient would get in front of an ER provider and care would start.
Right.
And now they're getting in front of that ER provider in less than 5 minutes. So it's things like that it's cool to be a part of. And we put quality metrics all around all those things, right? It's like, okay, well, those patients that we're treating on site, how many of those are going off site, within a 48-hour time period? And so we're monitoring that, and we know that patients will decompromise, things like that. And so we monitor that, and that's, maintain low single digits. And it's typically, it's part of the care plan. It's like, hey, let's give them this, give them a bolus of fluid, this and that. But if their blood pressure stays at this level, they need to go out, right? So it gives the nurse clear direction on what to do. And we collaborate with the on-site staff. The service is nothing without that on-site collaboration to be able to say, hey, are you comfortable with this treatment plan, carrying out this treatment plan? Because we've had scenarios. I remember this one early, and it's happened a couple of times where our provider would say, it's part of the script to make sure that they are comfortable, that there's nothing that they know that the provider does not know in carrying out this plan. And so our providers always end, are you comfortable carrying out this treatment plan? And I remember one early scenario where a nurse was like, typically I would, but the plan called for the nurse to monitor the patient over the next half hour, their vitals. I think they were getting fluid or something, some medication. And the nurse said, typically I would, but I'm the only one here, and I have to do a couple cell side checks, so I can't stay with this patient and monitor them. And the provider said, well, that's fine. We'll send them out then. Oh. And the nurse was like, are you serious? It was like they blew their mind. They just weren't ready for that. Yeah, if we cannot safely treat the patient on site, you are not comfortable with the treatment plan, then we will send them out. The safety of the patient will always come first in what we're doing. And So, once we got through some of those types of use cases, we had people that weren't sure about the service that became, evangelical about the service and big advocates. I'm like, you guys got to use this. I thought it was something different. I thought they were going to stop me from, sending things out, but they just help the process. They make it faster. Yeah. We've heard nurses say, you've allowed me to do more of what I know I can do, but you're allowed to, allowing me to use my skill sets to be able to treat patients. So it's, it's exciting to see that, especially when you've got people on the ground that are, like really excited to use it. We do a Net Promoter Score user experience for our nurses on site, and it's consistently above 70. And for those familiar, 70 to 100 is considered best in class. Yeah. So it's like really validates what we're seeing anecdotally played out in objective data.
Yeah, and it goes back to the concept of, is it the struggle between, is it telemedicine or in person, right? It's not one or the other. It's really both together. And sometimes it makes sense to do in person and to take them there. Sometimes it doesn't. And telemedicine is better. And it's not what's better, one or the other. It's them together is actually better than either of those two individually.
Yeah. I hate this whole thing that was created of, it's like telehealth versus in person. I'm like, when did this become like a UFC fight? Because to your point, and there's starting to be emerging studies around this of, a couple of things. One telehealth related, one not. One of like that combination of, it's not telehealth or in person, but the combination of the two, that hybrid care of maximizing your resources to take care of the patient is better. You're seeing this play out in a provider kind of parallel of, is our nurse practitioners good? Are they, are doctors way better? And they're finding out, what, actually the best model is a team-based model of physician-led advanced practice provider teams taking care of patient populations. So it's a similar type of like parallel that I've seen, and I think we'll see more of that because, medicine has become so complex and so specific in different areas that you're not in a position where the doctor can just see you at home on house calls. That same doctor is going to go into the inpatient, and they've got inpatient privilege. They can see you there. They're going to do all of, that same doctor is delivering your baby. Like but it's not that thing anymore. Yet all those things are needed. So you need that level of cross collaboration between provider teams, and that's collaboration between provider teams. That's sharing, data between provider teams to be able to improve the way we deliver care. And then hopefully, by doing this and using more technology, we start to get patients more engaged in their own healthcare that has never been there in the past. There's a lot of, we see how much engagement's happening with smartphones and social media with people. And if we can get that same type of connection and engagement with their own healthcare, invest in their own healthcare and communication with their physicians and providers, that will really be, I think, the next big tipping point of, the evolution of how healthcare is delivered in the U.S.
Let's talk about that a little bit more. I often like to ask my guests, what does healthcare look like 10 years from now? And is a perfect segue. What does, in your mind, what does ideal healthcare look like 10 years from now? And what do we need to do different that we're not doing now to get to that point?
Yeah, I think a lot of different things. I think one, kind of to the point I was saying, I think, it's going to be increasingly more patient-centric. You start to hear a lot more about, as opposed to, come to the provider's office, come here. It was very provider-centric. It's going to be increasingly more patient-centric, but still provider-led, provider leading the strategy to make it, patient-centric. A lot more data exchange. So we need more, the more data that's exchanged, the better typically for the patient, but also the more risk that comes along with that. So I think, the increased or enhanced security of data and exchange of data for the benefit of the patients, increase in regards to, artificial intelligence, natural language processing, machine learning, those types of things. We used some of that during the pandemic, where we were seeing, early on the correlation between the words lost, taste, and smell with positive patients COVID-19 through a natural language processing application that we used at MUSC, which allowed us to put those words into the virtual urgent screening or questions specific to that in the virtual urgent screening, evolution of that. So you're going to see a lot more of that, a lot more precision medicine and those types of things. So it'll be interesting, and even like remote patient monitoring, it's happening right now, but it is so in its infancy. So I think there has to be a lot worked out in regards to there's hey, we're going to pilot this, give you devices, because it's so at a pilot stage now. I mean, MUSC is doing some great work with like diabetes where they're doing, 500, 600, 700 patients at a time, but most people don't have things significantly at scale with remote patient monitoring. So I think you're going to see a lot of evolution of that over the next decade, and it's going to it needs to weed out the devices that have not been validated, that are not secure, and we've talked a lot at MUSC previously about a digital health formulary, because you've got all these applications online now, and many of them have not been tested and validated. There's some great work over in Europe right now with the company that does a lot of this, of validating different healthcare applications. To be able to say, because health organizations need to set this up like a pharmacy, right? A pharmacy formulary where you say, hey, these are medications that we feel comfortable with, we've got access to them, and this is what we're going to prescribe our patients. You need to do the same thing from a digital health standpoint when you get into using different devices. Like, hey, these are devices that our team has validated, checked, and we have a process and purpose on how to use these devices to make sure we know what data is coming back into our health system, and out of that data, what is going into the legal medical record, what is just part of this designated record set. And so there's a lot of decisions that people have to make that a lot of organizations aren't even thinking about this stuff now, and they really need to start thinking about it before stuff gets out of hand, and all of a sudden you've got doctors using different applications across the health system. Patients want to send a doctor their device. I'm pretty sure my doctor doesn't care how many steps I get every single day. They probably care that I'm active every day, or active, getting somewhat activity, X days out of X months, whatever that may be. And so I think having that data feeding dashboards in the future where you have nurses, and we do this right now with diabetes, so it's not like, hey, I have to monitor every single patient. You're monitoring a dashboard maybe of 1,000 patients, and out of that 1,000 patients, 200 or 180 or so are highlighted red for outside the norms, outside the blood pressure that the physician specifically set for them, outside the glucose range that their physician specifically set for them. So then you can have more precise interventions with those patients. And that's the type of thing of becoming more efficient with the limited resources that we have and will continue to have over the next 5-10 years.
Yeah, really focus on the patients who need it most, and not necessarily waste your time, but spend too much time on patients that don't need as much focus.
Healthcare has been too often this just like even spread of effort across. It's like I've got this visit with you. I'm gonna spend maybe 7 minutes, because it's supposed to be 15. I feel like it's always like a 7 minute, super quick, right? Yeah. So you go in the office and it's like a 7-minute visit with you, 7-minute visit with you. So they do that maybe through 20 patients. One of them is like a healthy surfer in their early 20s. Yeah. And one of them's got multiple chronic care conditions, and you're spending like equal time with these people. One might just be chatting up. One's like, gosh, wish we had more time to spend together. But so it's that type of thing of right sizing the care for the patient populations, so you can make sure you've got more frequent engagement. So you're going to have that. You can't forget about the healthy population. So you have to have some level of engagement with them, and some of that might be virtual urgent care. You might need to have the system set up to make sure they have reminders about colonoscopy screenings and different things that come up, get your flu vaccine, that type of engagement, versus the other side of the spectrum where you might have a diabetic CHF patient that needs remote patient monitoring or devices to keep a closer connection to that patient.
Shawn, thank you so much for your time today.
Absolutely, man. I always enjoy talking with you.